So this morning we'll have a short session on point of care in blood coagulation. So next slide, please. So quick overview, we're going to look at quality control in general, IQC, QA, and then I'm going to look at the specific test that we do here at blood coagulation, which is INR, D-dimer, Rotem-TEG, ACT. I'm going to look at a bit of background on each test and then some issues that we've come across and some troubleshooting. And then I'm going to finish off with looking at our reports. So just as a reminder, quality control, we like to think of it as in two arms or two pieces of the puzzle. So we've got external quality control and internal quality control, and the two fit together to give you good quality results and obviously good quality patient care. So we have produced a poster at our working party group on quality control that goes into detail about the differences between EQA and IQC, and it's a poster, so it's designed so that you can print it out and stick it on the wall. But in a nutshell, EQA is a spot check that's done at regular intervals and provided by your external provider. And IQC is something that you purchase yourself, you organise it yourself, you test it when you decide, and you react to its results yourself. So it's an internal process, and that can differ between organisations. So this came up in an earlier webinar that we did, questions about the frequency of IQC. So I thought I'd cover this here, but this is my information is really pertinent to the hemostasis, and other disciplines might have different opinions. But you need IQC to be frequently enough to ensure that you've got good quality results while still making it cost effective, the test. So you don't want to charge, you should be spending too much money on that to make it too expensive. But basically, if you have an IQC fail, you need to consider how many patients or how many tests you would have to redo, how many patients you would recall since the last time you had a good result. So for an example, we might have an INR clinic performing 20 tests per day, 5 days a week, and they might do their IQC first thing in the morning. And on the Friday morning, when they do their IQC, it fails, then they would stop testing and look at the previous day's IQC, which would be the Thursdays, and then they would have to consider if they're going to recall those 20 patients. They would look at the results and try and decide whether you're going to recall them all or just ones that you were suspicious of. And I think this seems a reasonable process for this particular setup. So my next example is from a GP surgery, and they perform maybe 10 tests a day once a week, and they think they're doing their IQC every 3 months, and they think that's adequate. So if they had a fail, they would stop using the device and then relook at the results since the last past IQC, but that would be over 3 months in time and 120 patients tests, and this is far too much time passed and far too many tests. So for this scenario, I would suggest that they should be doing it weekly or at the very minimum every other week. Another example is from an ACT IQC testing. So this is from a cardiac catheter lab, and they reported to me that they would do their IQC every morning first thing, and then they would receive any emergency patients. But some days they didn't get any patients, so they'd IQC'd it and not even done a test. And I explained to them that I felt this was a very expensive approach, but they said that they were completely happy with the cost of it, in the fact that once a patient came in, they needed to be ready to go. They didn't want to have to do IQC or even then try and find a new machine if there was any problem. So they were happy with that. So this really demonstrates that the IQC frequency needs to fit your work pattern. It needs to be applicable to what you're doing. And we can give guidance to that if you are struggling. Just email us with your specifics and we can try and give you some guidance. We do regular questionnaires to our users, and these are the results from a recent questionnaire for the point of care Coagulation testers. And we asked them how often they were doing IQC, and we let them choose as many of these options as they wanted. So the most chosen was with each new batch of test strips, which is good. And we also had monthly and weekly, if any unexpected. The ones that did surprise me were a 5% who stated that IQC wasn't available for their device. But and this is the case with some devices for INR, but not these particular ones. When I cross-checked these centres, they could do IQC, although they believed they didn't. So I think that's just a misunderstanding. So we need to try and tighten that up, that if it is available, they know about it. But also surprised us that 9% stated they never did IQC testing, which is a little bit alarming, because of course these centres are doing EQA, so they're doing nothing in the 3-month gap between. And when I checked on some of these, some of them were running up to 100 patients a month, which is a lot of testing to be doing without IQC, and I think this is not adequate. So another question that we got asked earlier in the webinar was, how do we engage the end user with QC? And I think that I like to tell the end users that although QC is a support tool, and people think of it is that it supports the patient, which obviously it does, but it also supports the operators. If there is a problem, a bad outcome, and procedures are viewed, if you haven't done the IQC, if you're not following the protocols, then it might be the operator themselves that's held accountable. And I think so you need that safety net. You need to check that your device has got its procedures in place before you do any testing. I think that's really important to press upon them and get them on board with doing both your IQC and your EQA. So I've titled this the how, what and who. So how, when we're doing the coagulation, most of the point of care testing devices actually need to see the clot forming, and then they decide on an endpoint, and then they give us the result. So it's really important that we manipulate the EQA samples in a way that gives you a good result. And so technique is important when you're testing our samples, and I'll come back to that in later slides. The samples that most of the devices are designed for are fresh whole blood, fresh out of a finger stick maybe, and we cannot supply EQA samples in that way. It would be completely impossible to send freshly drawn whole blood to 3,000 centres to test INR. So we do as close as possible, which something we call commutability, but we will we still have to use lyophilized citrate plasmas. So it does mean that the sample type is quite different for the end user from what they're used to with their patients. And of course, when we talk about the end users, it's staff that are trained to operate the devices for the patients may not be familiar with EQA and lab techniques. And we might have point of care teams supporting those who are familiar with EQA and the lab methods, but they don't really necessarily understand the patient's tests or the devices. So in general, I would say it's ideally the person who does the testing should do the IQC and EQA. And I think that comes back to engaging them to get them on board with doing QC. Once they're on board and see the value of it, then it really is better if they can perform those tests. So what do we do at blood coagulation? Well, we have a similar format for all our programs. So we send the same sample out to all the users of a particular device for testing. They test it and submit their results. Data is collected, and we find the median value, which is just by lining all the results up, and it's the midpoint of those. It's a posher way of doing the average, so it's less affected by any outliers. The acceptable range is then calculated around that median, and we show the median and the acceptable range on the report. If you're within that range, you're considered within consensus, and we do that with colour-coded green on our reports. And if you're not within the acceptable range, you're considered out with consensus, and that's colour-coded red on the reports. We try to make things very simplified because a lot of our point of care centres, point of care users aren't familiar with the lab methodology and the lab terminology, so we try to just use simple language. We contact any centres that are out with consensus 3 times consecutively to ask if they need any help, support, help with investigation. And if you don't do the test, it's the same as being out with consensus. So these are the tests that we do for point of care in blood coagulation. So I've put them in separate boxes, because in the blue box we have tests that we can compare to the lab. So the INR, which you should get good agreement if you're comparing with your lab, and the D-dimer. Now the D-dimer test is a tricky test because there's no standardization, so you not necessarily get the same value if you send a comparison check with the lab, but you should get the same clinical outcome. And then we've got the box tests in the green box, which are what we call global tests, and there's nothing that we compare these in the lab. So these are the ACT, these three, and then the Rotem Sigma, TEG 5000 and TEG 6. So they're looking at an overview of hemostasis, if you like, whereas the lab tests look at specific points of hemostasis. So it is tricky to get any comparison with the lab. So because of what they are testing are different, we find them placed in different areas. So INR and D-dimer, we can find them in primary and secondary care. INR's on wards and clinics, whereas the D-dimer, because of what we're using it for, and I'll come to that shortly, we find that in A&E and acute wards. With the ACT, because it's a measure of heparin on board, we're finding that always in secondary care, and it's in the cardiac wards and the cardiac theatres. And the Rotem and TEGs we find in theatres, obstetrics, ITU and research labs. Because these are based in so many different areas, then we find that loads of different types of staff will do the testing. So we might have lab staff, BMSs, MLAs, but also nurses, clinical staff, GPs, dentists, anaesthetists and ward staff. So it really is a mix, and they have a mix of backgrounds and maybe a mix of abilities. So I'm going to come into the specifics of the test now. So I'm going to start by looking at the INR test and give you just a little bit of background. So the INR stands for International Normalized Ratio, and it's a test that we use to monitor the dose of vitamin K antagonists, which are anticoagulants such as warfarin. Now with the warfarin therapy, it's very much not a size of one size fits all. So we do need to tailor it specifically to those patients, and even once we've got it sorted for a patient, it can be affected by so many things. Once you put them on other medication, if they've got an infection, and even herbal supplements or dietary intake can affect it. So we do need to do constant, fairly regular monitoring for these patients. So the advantages are straightforward with the INR testing. Most of the patients prefer to have a finger stick than a venipuncture. It's less invasive. You get fast results within a couple of minutes, and you can sit face to face with them and do any dose changes, so that you can really make sure that they've taken on any changes that they need. And as we've seen before, it can be set in various different locations. So have you seen the INR samples here on the left, which is actually me, is quite different to what we're sending them, which is this here for our EQA. So we've got 2 bottles that we send. We send lyophilized plasma that we've obtained from warfarin patient therapy, and we send a diluent that you use to make that back from a powder into a liquid sample. And you add all of the liquid to the powder with a little pipette provided, wait 2 minutes, and then test as you would a patient. So this first bit of the testing is very different to how you would obtain a patient sample, but once it's back to its liquid form and it's been sat for 2 minutes, it's fully dissolved, then you treat it exactly as you would a patient. So the device actually seeing on the test strip is being treated in the same way. And because it's genuine samples from genuine patients on warfarin therapy, then it's quite commutable at that point. But it can be difficult because patients' testing is very different, so it's quite different for the end users to do. So this is an example of surveys over time for one particular user, and this spans an 18-month period. So each one of these red dots is a survey. So we've got the 0 line, which is if you were scoring on the median for each survey, and the 15% that we allow is marked in grey. So these first 3 surveys are fairly close to the median line and in the grey box within consensus. And then we've got the following 3, which fit over a 9-month period, which are all reading higher than the median. So we wrote to this centre and asked them if they could look into this if they investigated to see what was happening, and they replied and said that the original operator had retired, new operator had taken over, and for the last 3 surveys. We suggested that they did some repeats, and if they could follow the instructions to make sure that it wasn't just an operator issue. And when the repeats were done, they were within limits, and the feedback was that the new operator had said she hadn't had any training, even though this covers a 9-month period, and that she didn't read the instructions. She just threw everything together because she hadn't got the time for that. It's a 2-minute process to follow, so the whole thing takes about 5 minutes. We provide pictorial instructions, and there's also a video to watch. So even if she hadn't had training from anybody locally, if she followed the instructions, the results should have been within the range. So the outcome of this was that poor technique led to inappropriate results. We didn't have any concerns about the device or test strips, but I've put probably in brackets because, as you can see, they've not been properly tested for 9 months. We hope that there was no other issues. And we can say that the EQA can't mimic the patient process, but it can provide reassurance that the device and test strips are working properly, but only if you follow the instructions and the operators have competence in this. And it can also flag up competence issues and people who are just bending the rules really and not following the instructions. It will show up in the testing. So I looked into this, what effect would it have if you didn't use all the liquid, because I suspected that that was what was happening. So I said earlier that we need to transfer all the liquid. And so this is a little test that we did within our lab, and we tested it 5 times, and this is the mean result of the 5. And this is the result if you add all the 0.9 mils. And the median value for this was 3, and the acceptable limits were 2.5 to 3.5. And as you can see, as you lose liquid, if you're not adding quite all, you start to get some movement, and by the time you get down to 0.6, you would have been outside that range. So it might not look very much, but you do need to make sure that all the liquid is added. And so really the bottom line is use all the diluents. And even if you need to make more than 1 trip with your little pipette, that's fine. That's what you need to do. The other thing that I'm concerned about with this centre was whether they were following the timings as well. So I said earlier that we leave it to reconstitute for 2 minutes, and then you test it as a patient sample. Once that 2 minutes, once that liquid has been added, a clot is starting to form, and if you leave it long enough, you will get a solid clot, and if you leave it longer still, that clot will dissolve as part of the lysis process. And so we did some testing on this, and you can see that if you test it sooner than 2 minutes, at 30 seconds, in this case I got a very similar result, but that we set 2 minutes to allow all the powder to dissolve properly. So 2 minutes gave us an INR of 2.8. You can see as you move further away from that, you start to get some differences. So at an hour, it's already moved to 3.6, which would have been outside the acceptable limits for this sample. And I've noted that I saw a clot in this sample, but once I gave it a little shake, the clot dissolved. So it looked like a perfectly normal sample again. And then as you leave it further, you get further prolongation of the INR. And at 4 hours, I noted that the sample was liquid but contained a clot. The bottom line here is follow the instructions on timings as well. You might think that I've gone slightly crazy leaving things for up to 24 hours, but this is a recent submission from our survey from a centre that said the results were high because the liquid was left standing for 24 hours. And we got a result of 5.1. The true reading should have been about 2.8. So we sent them a repeat sample and took this result out because it's not checking the test strips or instrument appropriately. So that's a very brief review of INR and where you can go wrong. I'm going to move on to D-dimer now. So D-dimer is something that we test. It immediately follows fibrinolysis. It can be used to measure ongoing illnesses such as DIC. It can all, but unfortunately, it's also raising other areas such as pregnancy, inflammation, and post-operatively. So it's not specific. But what we do use it for in this particular point of care setting is it's also raised if you've had a DVT or PE, and you can use it to determine whether a patient needs a further testing such as a scan. And this is its most common use in point of care testing. So, in hemostasis, the body wants to have free-flowing blood. If there's some kind of trauma, it will form a clot, and then after a while, we get fibrinolysis kicking in so that we've got free-flowing blood. So it's this circular, ongoing motion. So this is going to be interesting because my next slide function is not working, so Jen's having to do these, and these were supposed to whiz through quickly. But here we've got fibrinogen, we've got an E and 2 Ds. Next, please. And then when we have under the influence of thrombin, we have the fibrinogens lining up and linking, so you get your 2 Ds linking together. Next, please. And then you get long chains of fibrinogen. Next, please. And you get cross-linking occurring, and we've now got what we call a fibrin clot. You get all these Ds lining up, and then fibrinolysis kicks in under the influence of plasmin, and you get cutting of these cross-linking. Next, please. And you get bits shearing off, so you've got bigger bits, smaller bits, but they've all got these double Ds with them, so you've got your DDs. Next, please. And this is what we're actually measuring. This is our D dimer, a product of fibrinolysis. So we, as part of our EQA, we ask them to measure the value, the number of of the D dimer, but we also ask them for an interpretation. It is optional, but if you opt in to do this, we do actually score that interpretation, and we give a patient scenario to fit with the test, and they are required to say, is it further investigation or is it no further investigation? And we provide them with a well score that they should be used to. And this is to simulate what happens when a patient turns up and we test the IMR, the D dimer, and we look to see whether we're going to refer them for an ultrasound or not. So this is an example. So we look at the interpretations and we only score them if they're 80% or more. So if it's borderline, we don't score it. It just goes not assessed. But if it's 80% or more, this is considered the truth, and then everybody else is compared to that truth. If it's not reached, we don't interpret. So this is an example. We sent out a sample and we said this is from a 60-year-old man suspected of having a DVT with a 2-tier well score of 1. Now, well score of 2 or more, you would automatically send for a scan. So 0 or 1, it depends on what your D dimer level is. So this D dimer was 0.31 micrograms or 303 nanograms. It's the same number, it's just a different units in FEU. The cutoff for this is 0.5 or 500. So these are both well below the cutoff. 92% of users said no further investigation, which fits in with the below the cutoff and a well score of 1. 8% of users stated that the patient required further investigation, and these were out with consensus. So this is a fairly straightforward one. My second example is a little bit more complicated. So this is a median of 0.42 or 420 in FEU with the same method of a cutoff of a 0.5 or 500. 46% said further investigation. This is getting around to the borderline area. 53% no further, which would have been fine, but when we looked at the scenario we gave them, we said they had a well score of 3. Now, well score of 3 should have meant that everybody said further investigation. So these that said no further were inappropriate at this point, but they weren't scored because of our 80% rule, but we did put it in the report that you should have picked up this well score of 3. So it's important to consider both the scenario and the results obtained. So moving on to Rotem TEG. So on the left here, I've got the Rotem Sigma. You can see its little cartridge, and on the right, the TEG 6. Next, please. These are the most recent devices for viscoelastic methods of testing. They are desktop pieces of equipment. They're not handheld portable in the same way as an INR test. They're desktop. They're usually placed in theatres, and they help monitor patients so that we can provide the right blood replacement therapy. They can also be found in laboratories as a research tool, and as such they're used by lots of different members of staff, lots of different shift changes. In a theatre situation can be used by lots of personnel, and this means that sometimes the QC role is not assigned to anybody, and then it's the old adage of if it's nobody's job, everybody thinks somebody else is doing it, and then nobody actually does. So my recommendation would be to find somebody to be your QC champion in that theatre, somebody who's there most days regularly on the same shift, if that's even possible, so that they can really take charge of maintenance, keeping the devices clean, keeping the QCs in line. So this is what we get off the both the devices. So on the left I've got the Sigma, and on the right I've got the TEG6, and this is what we call the trace. Sometimes you get paper ones, or most regularly now they just appear on screen and you can download them. So this both start at time 0 when you start your test. There's a lag phase in both where we're waiting for clotting to start, and then you get the initial burst of coagulation. And for the Sigma, that's called the CT, the clotting time, and for the TEG6, it's the R time. Then we've got the time it takes for the clot to form to 20 millimeters, which is how it's measured in this particular test. And then that's the CFT for the Sigma, clot formation time, or the K time for the TEG. And we can then measure the angle for both of these. The steeper the angle, the quicker the clotting. And then for the Sigma, we measure maximum clot formation, MCF, or for the TEG, it's called MA, maximum amplitude. And then once you've reached your maximum, if you leave it long enough, you start getting the lysis, and the curve starts to go down again as the clot's broken up, and you get lysis parameters. Both of these devices are the newest from the company, so predecessors for both had manual pipetting, which was a bit tricky, especially for our non-lab trained users. But these, you literally just put your sample in the cartridge and away you go. So they should have got better precision than their predecessors. But again, there's no comparison to the lab, so that makes it a little bit tricky to see how well these are doing. So because they're often used in an emergency situation, it means that you might have set the EQA sample to reconstitute, and we wait 10 minutes in this case, and suddenly you might have a patient in that needs that device. And if this occurs, we can usually supply a repeat. So just bin that sample and ask us for a repeat. We ask for interpretation on these results in a similar way to the D-dimer, but in this case we don't score them, it's for information only. We really recommend that the end user themselves provide the information, and I'm going to show you why. So this is an example from the TEG6, and we send samples that challenge the devices. In this case, we saw no clotting or greater than 30 minutes with the CK-R time. And this is the initial burst of clot in the R time. And you can see that the normal range is up to 9 minutes. And the CKH, which contains the heparinase that counteracts any heparin on board, and this was also greater than 30 minutes. Normal range is up to 8.3. So both were prolonged abnormally. And we asked the interpretations for the CK, and 100% stated prolonged, which was great. And then we asked for interpretations for the CKH, which is indicator of heparin, and the options there are indicates presence of heparin or no heparin present, and 57 stated indicates presence of heparin, 57%. So it was split on this. Next slide, please, Jen. And but there was no heparin in this sample. It was a sample that was designed to mimic a patient whose blood was very diluted, maybe due to trauma. The medium of both was greater than 30. If there had been heparin present, the CKH should have corrected back down towards the normal range. So 57% got the interpretation incorrect for this sample. And I think this possibly because they looked at the normal ranges and said it was outside the normal range. So I'm going to finish with activated clotting time. So this is a measure of patients on heparin. It can be plus when it's used to check levels during an operation, so ACT plus at higher levels, or LR low range when they're more on therapy. And there is some devices that just use ACT, and there's some devices that are ACT testing that we don't have EQA for. So we don't have EQA for all the devices that are out there. These are the ones that we can provide for. So plus on the Hemocron and the Gem 100, LR on the Hemocron and Gem 100. These are both on the same device, so you could have the same device registered in 2 separate programs with us, just using different test cartridges. And then we also provide ACT on the iStat and Innovative devices. So the samples for this are quite different. So we've got delivered in a protective sleeve, this white thing, so that the users can break them safely. So in this little actual sample, you've got a glass vial that contains red cells and plasma lyophilized, and the outer casing contains the liquid used to reconstitute. So you break the inner glass vial, which mixes the two, the liquid and the lyophilized red cells and plasma, and test then. Again, timing and technique are important. So the Hemocron instructions said that you should allow the cartridges to come up to room temperature, and this can take up to an hour. And I think this is one place that it can go wrong if you're trying to rush it. You don't have time if they're not properly warmed up. We also recommend this. So that's for the cartridges. We also recommend that the samples are allowed to come up to temperature as well. Once it's been mixed, we recommend that you discard the first drop because there might be some caught in the cap that's not properly mixed, so you need to discard that. And if people don't stick to these, it can affect the results and give you an operator error type result. And it's because I said that they can be the same device, just in different programs, and it should make sure that you're registered for the correct program, because we have had users that have ongoing issues, and then when we investigate, they are using ACT plus cartridges, but they've registered for the LR program, so that's important. So this is an example, a very recent one, of poor performance on the ACT program. So again, the 0 line is if you got the median result each survey. We have 20% deviation for this survey, so the grayed out section would be within consensus. We start at survey 42 where they were within, but then these other several are out with. You'll note that 43 jumps to 46 because they missed re-registering for 2 surveys, so they missed a couple of surveys. Looking at these results, the first thing that springs to mind is operator technique, or maybe different operators doing this. So that's something that we suggested that they look into. The scatter, it's all over the place. They're not consistently high or low, and that's more typical of operator issue. We sent repeats to these. They are looking into it. They said they would do some retraining, and they're getting the manufacturer to come out and have a look as well. So this is an ongoing investigation. This was the next survey is currently live. I've just had a look. They are not entered any results yet, and it finishes on Friday. So I'm hoping, fingers crossed, that they will get round to doing some testing, because of course if you don't do the testing, you can't check the devices. So I'm going to finish with a quick review of how our reports look. We have recently introduced a new data system, and all our reports have been standardized, so they all have a summary page, some further pages with more data, and then a page explaining the scoring system. They have the our little logo on the left, the title, so that you can see exactly what it is you've got, the date of issue, and the date, the survey date. In this, under this little blue box, I've anonymized it. There's the center name and the serial number of the device. But on the front page, we have the code of the device, the result, the acceptable and how you did, and in this case within consensus. We have who signed off on this report and when the next survey is due, so you should always know when the next survey is coming. So the rest of the report, we've done the front page. The second page has a little bit more data. It has percent deviations and overall CV for that survey, and it has your graph that I was showing you earlier. So you can see that this centre is doing really well, nearly hitting the median, all within. So they are performing very well. And then the final page is all our terms and conditions, if you like, how we do the scoring, who we are, and all that kind of thing. Every report has date, version number, logo, email addresses as well. I'll come final slide nearly onto the conclusions. EQA that we designed is to test the device and test strips. Operator error can give the impression that the device is not working properly, so we need to get on board with the operators that they follow the instructions as best they can, so that we can avoid these operator issues, and then we're really checking the devices. If at that point you've ruled that out, then you should investigate any poor performances, and for that we can offer repeat samples and advice. We can also offer advice on other areas as well. You can always contact us. If you're struggling with the test generally, or your EQA or inputting data, just get in touch. If you need repeats, we generally have them available. And if you just want to give us some feedback, we're always happy to listen and hopefully improve, because we're here to help. And I'm going to finish with that. Thank you.